thank you very much for the introduction, and thank you for the invitation to a conference that I truly love. I was asked to give a talk on hormone receptor positive metastatic breast cancer, how I treat. And I don't think I'm going to be giving you any newer information, but really walking you through my logic of how you treat a disease where there's been an explosion of data in the last decade or so. And these are my disclosures. So as you know, over time, we really have seen the evolution of drugs in the realm of hormone receptor positive breast cancer, from the use of tamoxifen to the use of aromatase inhibitors, fulvestrant, a plethora of different CDK4/6 inhibitors, and of course, Alpolysium, which targets PIK3CA. Now, I'm not going to talk to you about these drugs in detail, but what I thought I would do, and slightly differently, is to ask key clinical questions that we as community oncologists will ask ourselves in the clinic when we're approaching these patients. The first question is, what is the optimal first-line therapy in the absence of a Bracker mutation? And I think this is a very important question as we start to test our patients more and more. We know over time, with the use of tamoxifen first-line, progression-free survival is about 6 months, going on to aromatase inhibitors 14 months. Using data derived from the Falcon trial, fulvestrant PFS was about 17 months. And now with the use of CDK4/6 plus an AI, we're seeing PFSs of approximately 28 months, translating into a 45% reduction in the risk of progression of disease. Now, you've seen this data before. We saw that the use of CDK4/6 inhibitors in that endocrine sensitive setting, in that first line setting, is associated with an overall survival advantage. You've seen this from data from MONALEESA 2 presented at ESMO, where you can see a 12-month benefit in overall survival benefit. MONALEESA 7, where we had a younger population, premenopausal, that were made postmenopausal, and of course MONALEESA 3 that looked at the combination of fulvestrant and ribociclib, and you can see that the hazard ratios across the board very, very similar in terms of improving that overall survival. We've seen that the use and combination of a CDK4/6 plus endocrine therapy in that first line setting, and this data comes from the MONALEESA 2 setting, exploratory subgroup analysis that shows, irrespective of the subtype that you're looking at, whether it's bone-only metastases, liver metastases, or more than 3 sites of disease, you can see a consistent improvement in long-term survival at 5 and 6 years with ribociclib observed across these cohorts. Now, the question was, does efficacy of CDK4/6 inhibitor differ by intrinsic subtype? And we've seen that data of the pooled analysis from MONALEESA 2, 3, and 7, showing us that when you added ribociclib to endocrine therapy, you did see an improvement in those patients with luminal A, B, as well as HER2 enriched. In fact, the biggest benefit you saw was in HER2 enriched group, but no benefit in the basal-like subgroup in terms of progression-free survival. And this year at San Antonio, we did see that even in terms of overall survival, you were seeing a consistent benefit across the intrinsic subtypes, but really not much of a benefit seen in those patients with the basal-like subtype in terms of improvement in overall survival. Now, using CDK4/6 inhibitors in that first-line setting doesn't only mean endocrine-sensitive patients. You also have patients who have got endocrine-resistant disease if they've relapsed early. And does it work in that endocrine-resistant setting? The simple answer is yes, it does work. There is an overall survival benefit. We've seen that data from Paloma 3, where there was a 6.9-month improvement in overall survival. Monarch 2 with the use of Abema, again 9.4-month improvement, and with MONALEESA 3, a 6-month improvement with the use of ribo in that endocrine-resistant setting. So really using CDK4/6 inhibitors in that first-line setting, whether endocrine-sensitive or endocrine-resistant, was associated with an overall survival benefit. But what is the optimal first-line therapy if you do have a Bracker mutation? And I think this is a very important question to ask. And the reason being that there's been accumulating data suggesting that endocrine therapy and CDK4/6 inhibitors don't work as well in this group of patients. A very interesting poster presented at ESMO last year showing data derived from the ESME database that in fact showed that if patients had BRCA wild type versus BRCA mutation positive disease, these were all patients hormone receptor positive, if you gave them first line endocrine therapy, in terms of PFS and in terms of OS, patients with BRCA mutation positive disease did worse. But if you gave them first-line chemotherapy, they actually did similar in these two cohorts, suggesting that germline BRCA was an independent adverse prognostic factor for patients treated with first-line endocrine therapy. Now, in the setting of using CDK4/6 inhibitors, now this data comes from the Flatiron database. Again, we're seeing that even if you use the CDK4/6 inhibitor, in terms of time to first subsequent therapy, and in terms of overall survival, you're seeing that patients who have germline mutation-positive disease are doing a lot worse than those who have germline wild-type disease. Now, these are patients who never used a PARP inhibitor. Last year at ASCO, we saw some interesting prospective data that came from our Korean colleagues that looked at prospectively evaluating patients who were using palbociclib and an AI in that endocrine-sensitive setting. And you can see in that subgroup of patients who have a BRCA1, BRCA2 mutation compared to those who do not, again, shorter PFS in these patients when they're using a CDK4/6 inhibitor. And of course, just recently at San Antonio, deriving data from the IMPACT database from Memorial Sloan Kettering, again, when you're using CDK4/6 inhibitors, either in the first line or at any time point, a worse progression-free survival when you have a germline mutation versus if you had wild-type disease. And some of the possible mechanisms hypothesized includes predisposition to biallelic loss or homologous recombination deficiency or conditional haploinsufficiency in those patients who've got an RB1 BRCA2 combination. So in the presence of a BRCA mutation, what are we going to use first? We know from the Olympia D trial, the Bracker trial, that using a PARP inhibitor versus physician choice of chemotherapy, PARP is better when there's a germline mutation. We also know from Olympia D, when they did the exploratory subgroup analysis, in terms of overall survival, the most benefit that you were seeing with the use of PARP inhibitor were in those patients with no prior chemotherapy, suggesting that we probably need to use PARP inhibitors earlier on rather than, in heavily pretreated group of patients. Now, this was a data set that I derived from a real world data set, the Trinitax data set. It comes from my research group, where we looked at patients who had triple negative as well as hormone receptor positive patients who had received a PARP inhibitor. And amongst those who had hormone receptor positive disease and had received a PARP inhibitor, you can see that those who had received a CDK4/6 versus who had not received a CDK4/6, very similar overall survival, really suggesting that perhaps CDK4/6 wasn't impacting the prognostic outcome by that much. So should we consider PARP inhibitors prior to CDK4/6? Should we combine a PARP inhibitor plus endocrine therapy in the upfront setting? Or should we consider a PARP inhibitor prior to exhausting all lines of endocrine therapy? And these are some of the questions that we will need to tackle in the clinic. The next question is, should we be using an ESR1 mutation to guide therapy? And we've just seen amazing data that came out from the PADA trial. And I won't go through this in much detail because this has already been discussed, but just very briefly, a very interesting trial taking patients first line endocrine sensitive, giving them an AI plus palbociclib and measuring using ctDNA analysis the ESR1 mutation at baseline, 1 month, and at 2 months. And if you found a rising ESR1 mutation prior to radiological evidence of progression of disease, really randomizing those patients to continue AI plus palbo or switching to fulvestrant plus palbo. Two interesting observations from this study. If you detected an ESR1 mutation at baseline, and this happened in about 3.2% of patients, they did have a worse prognostic outcome. Using AI plus palbo, some of these patients actually did clear their ESR1 mutation, which then later emerged. And if they were unable to clear the ESR1 mutation, again, they did worse than if they were able to clear that ESR1 mutation. Now, amongst patients who had a rising ESR1 mutation who were randomized to continue palbo plus AI, their PFS was 5.7 months, but they did a lot better if they were randomized to receive palbo plus fulvestrant. You see a PFS of 11.9 months, and this was significantly different between the two cohorts. Now, amongst the patients who had palbo plus AI, when they did have radiological evidence of progression, there was an optional choice to continue to then go on to fulvestrant plus palbo, and you can see a PFS of only about 3.5 months. So again, really suggesting that there's several questions we're going to ask ourselves in the clinic. Should ESR1 mutation monitoring now become the standard? And will this strategy translate into an overall survival advantage? Should baseline ESR1 mutation directs perhaps type of endocrine therapy partner that we should be using as baseline, such as fulvestrant or a SERD or an oral SERD therapy? Does disease burden make a difference? And I think that will make a difference in terms of trying to capture the ctDNA, in terms of trying to detect ESR1 mutation in these patients. And what are the cost implications of doing repeated ESR1 mutation? And would change ESR1 mutation detection, and would changing the type of CDK4/6 inhibitor have made a difference? These patients, if you remember, did continue palbociclib. And should we be using CDK4/6 inhibitors beyond progression of disease? Taking us very nicely into the next question. Can we in fact use a CDK4/6 inhibitor beyond progression of disease? We don't have, apart from the PADO-1 trial, we don't actually have a lot of prospective data to look at this, but we do have some retrospective data. We have the data from the Flatiron database, again, a poster presentation at San Antonio in 2020 that looked at patients hormone receptor positive who had progressed on a CDK4/6 and then used various lines of therapy. And you can see that the best group of patients in terms of PFS and OS are those patients who receive CDK4/6 inhibitors. But again, remember, this is retrospective with a lot of confounders that may have contributed to this cohort of patients doing this well. We did see a very interesting paper that was presented, that was published this year in the JNCCN, coming from a multi-institutional data set of looking at patients who had progressed on palbo and then at some time point switched to an abema combination with endocrine therapy or abema alone. And you can see a progression-free survival of 5.3 months and an overall survival about 17.2 months, with a total of 36.8% of patients receiving abema for more than 6 months. Is it a strategy that we do tend to use in the clinic? Yes, because we do tend to sometimes re-challenge our patients. But again, we need to wait for that prospective data. Can we use CDK4/6 inhibitors in the setting of visceral crisis? Something that we do think about frequently when we are seeing our patients in the clinic. Now, this is important information. Now, again, this is not data that comes from patients with visceral crisis, but this is an exploratory subgroup analysis from Monarch 3 that looked at abema plus an AI, and you can see that the response of patients in that group of patients with liver metastases, looking at abema plus an AI, is about 57.4%. And if you compared it to using single agent chemotherapy, it's 38%. Now, yes, these are not patients with visceral crisis, but you do get high response rates with a CDK4/6 inhibitor. Now, we did in my group look at, again, this is real world evidence, look at a cohort of patients with visceral crisis, again, retrospective data where patients were given CDK4/6 inhibitor plus endocrine therapy, and there was a 5-month improvement in overall survival. These were patients who had pancytopenia secondary to bone marrow infiltration, pneumonitis, or even deranged liver function, suggesting visceral crisis from a liver perspective. Again, retrospective, not prospective, but at least some preliminary evidence that you could consider it in patients who refuse chemotherapy. And finally, when should we be profiling our tumors for the identification of other biomarkers? And I think this is very important because there are so many biomarkers that we could be thinking about where we have targets to treat in that hormone receptor positive, HER2 negative cohort of patients. We have patients who can have PIK3CA mutation. We have data from the SOLAR-1 trial that shows that using alpolysium plus endocrine therapy in the setting of a PIK3CA mutation does result in an improvement in progression-free survival, overall survival, especially in those patients with lung and liver metastases. But these were patients, very few of whom had actually been pre-treated with CDK4/6 inhibitors. We then have data from BYLieve trials showing that you can in fact use alpolysium plus fulvestrant or alpolysium plus an AI in pre-treated patients who had a CDK4/6 inhibitors, and you get a very decent median progression-free survival, but not as much as if they had not used a CDK4/6 inhibitor. Does duration of pre-treatment with CDK4/6 inhibitor make a difference with the impact impact of using alpelisib? Simple answer is no. Byleaf tells us that even if patients rapidly progress on CDK4/6, they still do tend to do well with alpelisib plus endocrine therapy. What about patients who've got a somatic germline BRCA? We have data that shows that if you use a PARP inhibitor, whether germline or somatic, in a variety of different tumors, it does not make a difference. It works very, very well. And we do have data from the TBCRC trial, specifically looking at the use of olaparib in those patients with a somatic BRCA1, BRCA2, 50% response. So again, doing very well. And finally, I think very important, HER2 mutation positive patients, you get about 8% of patients who acquire a HER2 mutation who've got hormone receptor positive HER2 negative disease. And we do have data from the Summit trial that looked at the combination of neratinib, fulvestrant, and trastuzumab, and that was presented at San Antonio this year. They had a randomized cohort and a non-randomized cohort. And you can see in the randomized cohort, those patients who got triplet therapy had an objective response rate of 28.6%, but those patients who did not receive neratinib, either fulvestrant, trastuzumab alone or fulvestrant alone, had absolutely no responses, really suggesting that neratinib is vital in these patients. And when you looked at an aggregate of 33 patients getting triplet therapy, you can see an objective response rate of 42%, a clinical benefit rate of 51%, and a median progression-free survival of almost 7 months. What about agnostic markers like MSI? We know that MSI high patients, when you give them immunotherapy, 54% response rate, and we know that 1.7% of primary breast cancer patients are MMR deficient. I currently have 2 patients in my clinic that I'm giving immunotherapy for these patients. And then I think probably for me, the most interesting data that has come out in 2021 is to look at the use of immune checkpoint inhibitors in those patients with high TMB. We know the FDA has approved TMB as an agnostic marker in patients enrolled from the Keynote 158, but there were no breast cancer patients enrolled in that trial. So this year, or 2021, we saw 3 very important pieces of data. One was a real-world data set, again, presented at ESMO last year, looking at patients with hormone receptor-positive, HER2-negative disease, real-world data of patients treated with immune checkpoint inhibitors if they had a high TMB, and they found some very decent time to progression of disease in these patients when you used immune checkpoint inhibitors in these patients. We then saw the results of the TAPER trial that looked at the use of pembrolizumab in patients with a TMB of 9 and above. Again, you can see an objective response rate of 21%, a median progression-free survival of 10.6 weeks, and a median overall survival of 30.6 weeks, and 43% of these patients had hormone receptor positive disease. And finally, at San Antonio, we saw the results of the Nimbus trial, a prospective phase 2 trial, looking at the combination of nivolumab and ipilimumab in patients with high TMB. 70% had hormone receptor positive disease, and you can see an overall response rate of 16.7%. In those patients with TMB of more than 14, 60%. Again, very small cohort, I think hypothesis generating, but again, something that we need to think about when we're profiling our patients. And finally, we can't forget to actually test for TRK or NTRK. They do constitute a small proportion of our breast cancer patients. We know when we use entrectinib or larotrectinib, we do get good results. I have 2 patients, again, in my clinic who've got TRK fusions. We know that, again, a very small proportion of our patients, especially those with secretory breast cancers, do have NTRK fusions. And if you do detect them, you will get some very prolonged responses. So again, what do I do in my clinic? This is my last slide. And this is a disclaimer that this is just the way that I interpret my data. I first ask the question when a patient comes in the clinic, do they have visceral crisis or not? If they don't have visceral crisis, and these are all patients endocrine sensitive, we do start off CDK4/6 plus an AI, irrespective of the BRCA mutation status, because we know that there's an overall survival advantage, and we have no prospective data to see what is the optimal first line. All our patients then undergo molecular profiling, and then we see what sort of targets that they have. If they've got a PIK3CA, we do consider Alpolysium. If they've got a Bracker or a PALB2 PARP inhibitor, if they've got a HER2 mutation, of course, triplet therapy. And of course, we do look at that agnostic group of patients who've got NTRK, MSI, and TMB. If they do have a visceral crisis, now this is just flipped, I'm sorry, this should be saying yes over here. If they do have visceral crisis, we ask the question, do they agree? Does the patient agree to get chemotherapy? If yes, they will get chemotherapy, and then we will maintain them on endocrine therapy with a CDK4/6 inhibitor. There is data from the Complement E trial that shows that it does work in these patients. And if they do not agree with chemotherapy, and we do have patients in our part of the world who refuse categorically chemotherapy, we will use endocrine therapy with a CDK4/6 inhibitors. And I'm sure all of us have had very good responses in those patients. So thank you very much.